Happy New Year. Thank you for joining us for the first of the 2022 version of the section of Health Services Research and Quality Clinical Lecture Series. We have lots of great things lined up for this year, and we're very excited, and we're very excited about today's presentation as well. Today, we're going to be joined by Dr. Chad Ellimoottil. Dr. Ellimoottil is an assistant professor here at the Department of Urology here at Michigan Medicine. And he is the director of the Institute for Healthcare Policy and Innovation's Telehealth Research Incubator. I've had the opportunity to work with him on several projects as well as some grant proposals. And so we're very interested and excited to hear back on that soon. But mostly his research focuses on optimizing the delivery of telehealth and its impact on access, cost, and quality of care. He is funded by the Agency for Healthcare Research and Quality and the Michigan Health Endowment Fund. And he has been invited to speak about telehealth on NPR as well as Freakonomics. If anyone listens to that, it was a very cool experience to hear a friend and colleague on Freakonomics, which I've listened to for probably 7 or 8 years. So that was really cool. But additionally has served as a subject matter expert on telehealth for Department of Health and Human Services. Aside from his research, he's the medical director of telehealth for the urology department and has led the growth of telehealth in this department from 50 to 1,000 visits per month. And as a practicing clinician has been using telehealth regularly with hundreds of his own patients over the last 5 years and has some extensive firsthand knowledge on the advantages and disadvantages of this model of healthcare delivery. So Chad, thank you for joining us today.
Of course.
Before I turn it over to you, just a few housekeeping items. This is a webinar format, so you shouldn't have to worry about audio or video. This is being recorded, and if you have any concerns, please go to the Q&A or reach out to us about this. The presentation portion of this session will be available. The Q&A portion will not, but this will be recorded and available if anyone would like to review it or see it later. One contact hour will be provided for today's session for CME. This is a disclosure statement. Here's the QR code for CME today. I will also bring this up at the end. So if you do not get it now, don't worry, we will bring it back up at the end of the session as well. So again, thanks everyone for coming. If you do have any contact or questions or suggestions for future speakers, please reach out to any of us here. We look forward to hearing back on any topics. And if you have questions during the presentation, feel free to put them in the Q&A or the chat, and we will either address them as we go along, or at the end of the session, we will leave time for Q&A as well. So with that, Chad, I will turn it over to you. And again, thanks for joining us today.
Of course, very happy to be here and talk, Mike, and I really appreciate it. And I really appreciate all the collaboration that you've done, over the last couple of years. So it's really a joy here. And Donnie, I see you out there too. So you look really comfortable on that couch. Can you guys see my screen okay and the slides?
Yes, we're good to go.
Awesome, thank you. And so I appreciate the invite. I'll be talking primarily about telehealth. I'm, as Mike mentioned, I'm a health services researcher. So my interest is really looking at the population level impact of telehealth. And, I won't go through my bio again, but essentially I've kind of had this lens into telehealth from 3 different perspectives. I think most important is the clinical perspective. And when I came here in 2016, I noticed that there were a lot of patients that were coming to see me. I'm a urologist. I'd see patients for kidney stones, for example. They were traveling hour and a half to come see me for a 15-minute consultation where I told them that everything looks okay and I'll see you in 6 months. And that just didn't, it seemed like there were other ways that we could do this. So back then we bundled together some, clunky way of performing video visits with these patients. And, really things have obviously taken off since then. But I always kind of go back to that model when I think about our research and how it's important to keep telehealth going, because it really does benefit patients. And on the research side, I primarily study telehealth using a population level databases and population level metrics, and I'll talk about those in more detail later. And then obviously on the operations side, helping the Department of Urology grow. And the whole point of it as a health services researcher is really to be able to, again, inform national health policy so that we were able to optimize the delivery of telehealth. And just a quick explanation of the lab. So what's the why of the lab? Why am I interested in this and why am I passionate about this? And really it's because when clinically appropriate, I feel like telehealth is a very effective way to deliver healthcare. It's a very straightforward, very effective way to deliver healthcare. But there is a lot that we do not know about the impact of telehealth on the healthcare system, on healthcare cost, quality, patient experience, access. So there's a lot for us to learn. I do fear that even though telehealth has been around for a long time, it's relatively new in terms of wide use, and without proper evidence, policymaking can either make or break telehealth. So that's why I'm focused on studying this population level impact and why we've done the studies that we have. So this talk is primarily policy focused. I want to kind of give you guys an idea of what things look like in the future. What are the conversations happening in DC around post-pandemic telehealth? And so to do that, we'll go over trends, we'll talk about the policy landscape, but throughout the whole talk, I'll weave in research that our lab has done that hopefully helps to inform a small slice of these big policy discussions that are occurring. So just to level set, what is telehealth? And when I use that word, what do I mean? Telehealth in general is the use of remote technology to diagnose, treat, and manage disease. It's a paradigm shift where all healthcare that is delivered is moving away from the specific clinical setting to technological forms, like it could be video visits, telephone, email, portal messages. And there's an obvious shift that way. I don't think insurers and other organizations have actually viewed telehealth as a way to deliver healthcare. It's just more of stuff that clinicians have done on the side, but more and more it's being recognized that way and formally reimbursed. So that's the big change. Virtual care, telehealth, telemedicine, digital health, and at some point, these had different definitions, but nowadays everyone uses them interchangeably, and I'll use them interchangeably in this talk. And so for people that are new to telehealth, they may be surprised to know that telehealth has actually been around for decades, but it's just barely been used as a way to deliver healthcare. In fact, the Medicare program started reimbursing telehealth back in 2001, so 20 years ago. But it was really restricted to patients that live in rural areas, and you couldn't connect from home. You actually had to go to a medical facility in order to perform telehealth. So there were a lot of restrictions that held telehealth back for the last 20 years. But over the last 5 years or so, there's been more attention towards this and regulations that have been loosened that actually allowed telehealth to grow, not flourish, but just grow. The VA system, for those of you that work out the VA, they've always been ahead of the curve. They've been ahead of the curve in electronic medical records. They've been ahead of the curve in telehealth. In 2019, the VA system performed 2.6 million telehealth visits nationally. So they were ahead of the private sector. Some Medicaid programs were ahead of the curve. Medicaid allowed patients to connect from home, even in our state of Michigan prior to the pandemic. Commercial payers were starting to get ahead of the curve. Blue Cross Blue Shield, as everyone knows, a big payer in the state of Michigan, allowed patients to connect from home, started reimbursing telephone calls back in 2016. So people were really gearing up for this. And Medicare was interested. They were doing demonstration projects for very specific clinical diseases or particular payment programs. And so people were interested. There was attention towards telehealth, but in February of 2020, less than 1% of care being delivered in the United States was delivered via telehealth, and less than 1% of healthcare providers ever did a telehealth visit. So it was actually rarely used for routine care. But obviously, as everyone knows, in March 2020, things changed. There was a strong desire for social distancing, but then that desire was also coupled with major regulatory reforms, which changed the environment for telehealth and allowed it to flourish. Patients were allowed to connect from home. They didn't need to be in a rural area. There was this concept of payment parity, so the providers were reimbursed at the same level. Providers were allowed to practice across state lines. patients had their co-payments waived, and then a lot of the privacy rules that regulated telehealth were also relaxed during this time period too. This is the national public health emergency, and that's what started in March 2021, and that's what allowed many of these regulations to be waived at that time. And we're still in this public health emergency, and these regulations are still waived. So a lot of the thinking is more about what's going to happen after this, after the public health emergency officially expires. But during this time period, there was a response because of these regulations and because of the desire for social distancing. Telehealth did grow. This is data from our lab where we used national Medicare data to understand the trend in telehealth. And you can see in March, April, May that there was a drop in outpatient care. We all experienced that at Michigan Medicine. About 60 to 70% of care was deferred at that time. And during that time period, telehealth did salvage some of it. Telehealth salvaged about 30% of the care that was being delivered in the early part of the pandemic. And then as in-person care became safer, patients started to come back in, and telehealth tapered off a little bit. And if you look at this data and even more recent data, you can see that telehealth has kind of plateaued, and essentially it's at 15 to 20% of care being delivered in the United States right now remains through telehealth. And so what's going to happen in the future? That's the big question. Is telehealth here to stay? Is it going to change? I think that there's no doubt in my mind, and anyone that follows telehealth policy will tell you that there's no doubt that telehealth is going to be a big part of healthcare delivery in the future. This is a quote from the former head of the CMS program, but the Medicare program. I still use her quote because her quote embodies what most policymakers, no matter what side of the aisle you're on, believe. With these transformative changes unleashed, it's hard to imagine merely reverting back to the way things were before. So there's no way that telehealth regulations are all going to come back. But there is a lot of discussion, and this is where the rest of the talk is focused. There's a lot of discussion on what the final shape and form of telehealth should be. And primarily, these are some of the biggest topics that policymakers are discussing related to post-pandemic or post-public health emergency telehealth policy. First is that removing the originating site. And that was that requirement I mentioned earlier, the reason that telehealth was hindered or restricted, that it was limited to people in patients in rural areas. And so that's something that's being discussed. Should we remove that permanently? Coverage for audio only telehealth. So should telephone calls, if you did an entire visit with the patient using the phone, should that be reimbursed in the future? I'm going to get into some of these policy issues in a little bit more detail. That's why I'm briefly going over them now. Telehealth across state lines. So should you be able to practice telehealth with anyone, anywhere in the country, or should you be limited to where your license allows you to? What should be the payment rate for telehealth? Should telehealth video visits be paid less than standard visits because they use less resources? That's a discussion that's going on actively in the country right now. What's clinically appropriate telehealth? Should there be certain diagnoses that you can do through telehealth, and should insurers set up guardrails so that you can't do other types of clinical activity through telehealth? A lot of discussion in this area. Fraud, abuse, and overuse. How do we prevent that? What are the compliance rules? One of the reasons that small practices, rural practices were able to do telehealth is because doctors were able to use whatever technology they wanted. My mom did a telehealth visit, and her doctor called her through FaceTime. That wasn't allowed before the pandemic. It's allowed now. Should it be allowed in the future? And then there's other issues related to certain types of insurance plans, like high deductible plans, and how you handle those with after the pandemic is over. And one thing that's a big theme in a lot of the policy discussions is the lack of data. In a lot of ways, even though telehealth has been around for a long time, because it was barely used, there isn't enough data to really support a lot of the policy discussions that are occurring right now. These are quotes from a group of senators and from the Medicare Payment Advisory Commission about stressing the need to inform policymaking with good data. And that's what, that's the heart of our lab. And what we're essentially looking at as health services researchers is the population level impact of telehealth. And over the last couple of years, we've published studies in these very specific areas. So I'm going to talk about 6 policy issues. Obviously, there's a lot more, and there's a lot of data out there for each one of these issues as well. So what I'll specifically do is outline each one of these policies, very specific policy issues, and then talk about some of the data that our lab has put together to help inform policymaking in this space. So the first policy issue is this concept of the originating site. And so the originating site prior to March 2020 meant that patients had to be within a medical facility and in a rural area in order to participate in telehealth. And so obviously this is something that's held back the expansion of telehealth, but during the public health emergency, the originating site requirement was eliminated. So patients were allowed to connect from home. You could be in an urban area or in a rural area. So one decision that has to be made after the pandemic is over, should the originating site requirement be permanently eliminated? And in terms of the status of where this policy is and where the discussions are, I have no question at all that this is going to be eliminated. There are numerous, and it's too many to list, numerous bipartisan bills that support the removal of this originating site. I think people understand that this is an essential first step to permanently allow telehealth to be reimbursed, and we have no doubt that it's going to go away, and it really should. And I want to highlight one of the bills out there that has the most momentum right now. It's called the Connect for Healthcare Act of 2021. So if you're interested in healthcare policy related to telehealth, this is really the only bill that you need to know about, because this is the one that's likely going to get passed. It has the most momentum, and it is also the one that's the broadest in terms of what it allows. Lots of bipartisan co-sponsorship, not just support, but co-sponsors. There's 61 senators that co-sponsored this bill. In the House of Representatives, over 100 bipartisan representatives co-sponsored this bill. And there's two big provisions. There's a few provisions, but the two main ones: one, eliminate that originating site requirement, and then two, probably the most powerful, is to provide the Department of Health and Human Service the ability to waive telehealth restrictions. So essentially look at the data and be able to make decisions on how telehealth is administered without having to go through the lawmaking process. That's going to give a lot of flexibility to the Medicare program. And as we all know, commercial payers tend to follow Medicare. So that's going to be probably the biggest change to telehealth regulation in the future is once this passes, it can be done in a flexible manner. Will this pass? Yes, it's unclear when it's going to happen. So even though there's a lot of co-sponsorship here, it hasn't moved very far because of all the other things that are going on. And but most people in DC would agree that this public health emergency, especially with the new variant, is going to continue deep into 2022. So a lot of the provisions that are in place due to the public health emergency will still be there. So there's no worry about pulling the rug out or this telehealth cliff where everything gets taken away immediately overnight. I think that there's going to be a lot of lead time into that. More data from our lab. This is just kind of displaying the state of Michigan telehealth visits per 1,000 beneficiaries in counties in the state of Michigan. And this illustrates the need for removal of the originating site. The first map on the left-hand side is 2019, and on the right-hand side is 2020. And you can see using the color-coded map here that telehealth use was pretty densely focused in urban areas. It was all over the state, but particularly in urban areas. So there are a lot of patients that are benefiting from telehealth that are all over the state, not just in rural areas like it was, back with the originating site. So I think that this is for sure a regulation that will go away. It's just a matter of when it will go away. Policy issue number 2 is a little bit more complex. So this is related to coverage for audio-only telehealth. And so prior to March 2020, the Medicare program did not cover phone calls with patients. And so we made phone calls with patients all the time, but could you bill for it? You couldn't. And when we're talking about phone calls with patients, we don't mean calling patients to quickly give them a result, telling them that their CT scan looks normal. This is a substituting a full outpatient visit with the patient, an evaluation and management visit with the patient through the telephone. So doing the entire encounter that way. And that was never allowed. It was never covered by the Medicare program, but during the public health emergency, it was. And initially, interestingly, in March, it wasn't. And then there was just so much pushback because health systems couldn't get video visits going in time. Patients didn't have access, and you wanted to do social distancing. And so the Medicare program eventually did allow it. But the question is, should they allow it after the public health emergency? And currently, as it stands, once the public health emergency expires, so does the coverage for audio-only telehealth does expire too, because there is a law change that is required in order to allow Medicare program to legally reimburse video phone visits. And that law change could happen through the Connect for Healthcare Act. So if that does pass, then that law can be changed. Most organizations do support this. Payers are very weary about this, and they are very concerned that it's going to lead to overutilization. So if you hear the arguments, oftentimes the narrative that's sold is that doctors are just going to start calling patients left and right and try to bill up their patients. So that's what payers are worried about. Obviously, I don't believe that, but I think that it is important to have some data in terms of understanding who's going to get impacted when if this type of policy does occur. And so this was a study that we did last year. It was led by Julia Chen and I, trying to understand who is using video visits and who is using audio-only telehealth. We wanted to specifically understand the demographic, socioeconomic, and geographic factors that would predict the use of video consultations with patients versus doing consultations with that are completely over the phone. And so we used an interesting time period for this. This was early on in the pandemic. So we used data from Michigan Medicine from April to June 2020. And I think that ideally this is a good time period to study this question, because this was a period of time when patients really had four choices. They could do in-person care, they could defer care, they can do a video visit, or they can do a telephone call. And they had to pick one of these. And most people were deferring in-person care. I think it's harder to do the same study now because the patients that can't do video visits are just coming in person. So during this time, in-person care was very low. So patients had to decide really between video visits and telephone calls. The people that were picking telephone calls were probably not picking it because they thought that they were going to get better care. They were picking it because they didn't have the means to do a video visit. At that time, University of Michigan, in February of 2020, University of Michigan was doing about 400 video visits per month. And so they had the capabilities, and we weren't doing it at a wide scale, but they had the capabilities to encourage patients to do video visits. So it wasn't a health system issue that would keep patients from doing video visits. And so we looked at that entire data set of patients, and we calculated something called average marginal effects, which is essentially calculating the probability that patients would choose video versus audio. And so what we found were the strongest predictors of not using video visits and using audio visits instead was age. There was a pretty strong correlation there. Being African-American, needing an interpreter. And we did have virtual interpreter services at that time, but that was still a big predictor of having your visit over the phone instead of through video, being on Medicaid, or living in an area that had low broadband access. That was also a big predictor too. And another important thing that came out of this study was that it wasn't just about specific demographics of patients that had a lower probability of using video, but also many of these patients had more than one factor. So there was this cumulative effect of multiple factors on the probability of using video. If you were young, not on Medicaid and no interpreter, about a 90% chance that you would do a video visit during that time period. If you were over 65 and on Medicaid, 37% chance that you would do a video visit. And then if you were over 65 on Medicaid and needed an interpreter, 19% chance that you would do a probability that you would do a video visit. And most of these patients were doing audio only visits during that time. So the summary of that study is that age, race, non-English speaking, Medicaid and broadband access impact the use of video visits, and the cumulative effect of these factors could be profound. And I think the important policy relevance is that the elimination of audio only telehealth coverage will reduce remote healthcare access for some patients. Sure, they'll still be able to come in, but there will be a disparity that's created because they won't have that access to remote care. So the third policy issue that we'll talk about today is telehealth across state lines. So telehealth across state lines is called interstate telehealth. And this is something that no one really cared about prior to the pandemic. So prior to March 2020, medical licensure rules required patients to be in the state where the clinician is licensed. So if I'm a provider in the state of Michigan, I can't provide care to patients that are physically located in the state of Ohio unless I have a license in Ohio. If I'm performing telehealth with a patient that lives in the state of Michigan, but then they go to Florida for vacation, I can't technically provide healthcare to them because then I'll be practicing in the state of Florida. So this doesn't matter as much if you're doing in-person care because patients are driving across borders all the time, but for telehealth, it's very significant. And so during the public health emergency, we immediately realized that this was an issue. When we're in Southeast Michigan, we have patients that are across the border 45 minutes and they couldn't perform telehealth visits because of licensure rules. So there was a lot of pressure on state governors to relax these licensure rules. And 50 out of 50 states did relax their licensure rules so that you could practice with any patient across the country during the public health emergency. But those executive orders, they were mostly governor executive orders, they did start to expire. The latest data I have is from November of 2021, and only 19 states have these flexibilities in place right now. So these are quickly expiring. State of Michigan, it expired in October. So these licensure rules are coming back. So, and there is a lot of debate here. There's a lot of federal and state policies that are being considered. I won't go into all the details of the policy discussion here, but there's people that are adamantly against it, allowing providers to practice across state lines, and there's people that are adamantly for it. But so the real question is, how do we prioritize interstate telehealth? There's a variety of policy options, but really no data out there to inform these conversations. And so that's what motivated a recent study that we performed, which is under review right now. And we wanted to understand how during this time period where there was licensure deregulation, when there was a lot of flexibility for practicing across state lines, how did patients, the Medicare patients, use interstate telehealth or have visits across state lines? So we studied the trends in the use of interstate telehealth by Medicare beneficiaries, and this is one of our findings. And so this is a graph. There's two lines on the graph, time graph, and so the black line there represents the percentage of all E&M services, so percentage of all outpatient services, in-person telehealth that were interstate telehealth. And what you can see is over time, very low percent just because there was such a low percentage of telehealth in general. But then as telehealth grew, there was an increase, and then it came back down, just following the trend that we always see. And that black line lands at around 1%. So of all E&M services, interstate telehealth makes up about 0.82% to be precise of monthly services, a very small percent. And then the orange line up there represents the percent of all telehealth, so not in person, but just telehealth that's made up of telehealth across state lines. And of course, that percentage is higher, but still only about 5.5% of visits in 2020. So as we started to study this in more depth to understand the magnitude and other trends, we found that there was actually a pretty strong need to study this at a state level, because this differed pretty widely at the state level. There were some states that had a high percentage of their visits via interstate telehealth, Washington, DC, Vermont, New Hampshire. But for about 51% of the states, less than 1% of visits were performed, telehealth visits were performed across state lines. And when they did occur, 2 out of 3 of them occurred with a bordering state. So this is our map that looks at the percentage of telehealth visits occurring across state lines. And so the main takeaway is telehealth, interstate telehealth is small in magnitude. It's not as, and there's a lot of stories about cutting off care to patients. And in reality, it's actually small in magnitude, less than 1% of all monthly visits, 5 to 7% of telehealth visits. The magnitude varies by state, and most of interstate telehealth is with bordering states. Some data that I didn't show, but we also calculated, was the percentage of these visits across state lines that are new patient visits. It was less than 3%. And there was more rural patients that used interstate telehealth than urban patients. So the policy relevance is that states should really handle this. This should be handled at the state level because there is state by state variation. Overall, for the entire Medicare program, this is a small percentage of overall care that's being delivered, but for some states, it can be pretty significant. And so they can prioritize their needs based on their own specific situation. All right, so I'm going to talk about policy issue number 5 now. So policy issue number 5 is related to payment rates for telehealth. This is obviously a big contentious issue that's being discussed right now. So should telehealth be paid equally, or should it be paid less? And prior to March 2020, telehealth was reimbursed equally by some insurers like Blue Cross Blue Shield, for example, and less by other insurers. The Medicare program actually paid slightly less for telehealth visits, and I won't get into the details of it, but the way it worked out was that the payment rate was slightly lower. And then during the public health emergency, we needed to encourage social distancing, so payment parity was established. But the question is going to be, after the public health emergency is over, should telehealth visits be reimbursed at a lower rate, or should they be reimbursed at an equal rate? And this concept, this policy concept, is called payment parity. And if there's anything that gets arguments going, it's payment parity for telehealth. And so there's commercial payment parity bills that are out there at the state level. The Medicare program really hasn't signaled one way or another whether they're going to lower payment rates. There have been some recommendations from reputable organizations about lowering rates for telehealth. But it's still unclear whether Medicare will do that. But certainly commercial payers are fighting this at the state level. All the bills that are out there, including the state of Michigan, related to payment parity, are being fought ferociously. And it may not necessarily be about how much they want to pay, but it's more about being regulated or being stuck to a single price, since commercial payers typically negotiate their rates. There's a lot to this, and it's a lot to unpack. I did write a blog article that kind of outlines this idea of payment parity and why it's important. But really the big issues are, is there any clinical difference between what is being delivered via telehealth versus in person? Does telehealth just automatically propagate low value care? If you pay the same amount, are you going to encourage people to just do quick visits that are low value? Will payment parity lead to overuse? Is there going to be doctors, again, that image of doctors just calling patients to bill them? Is that going to happen? And does the cost of and most importantly and fundamentally, does the cost of delivering telehealth differ than in-person care? And I actually go through these arguments in this article if anyone's interested, and try to address this specific topic that obviously has a lot of different perspectives on it. I do have some data I can share. Specifically, we'll talk about payment parity and overuse, that particular concern, and then some basic data that we have on the cost of delivering telehealth versus in-person care. So I'm putting that slide back up again that shows the national trend in the use of telehealth. And I want to draw your attention to the line at the top here. And the line at the top is the median number of monthly visits that were done in 2019. So the entire 2019, each month, how many visits are being conducted. And the reason I'm illustrating this is because it's showing that even with wide use of telehealth, with payment parity, you're not seeing a huge growth in telehealth. What you're actually seeing is plateauing, and you're also seeing that telehealth is, for the most part, a substitute for care. So if you look at the total care line there, which is the orange line, you're seeing that it's not exceeding the median number of monthly E&M visits that were performed in 2019. Now, people will argue, well, that's because patients are just not getting as much care as they were back in 2019. Maybe they're still worried about the virus and foregoing care, and that's a legitimate argument. But at this point, we don't see any evidence that there's overuse of care just because telehealth is available and paid at the same rate. We can replicate this finding in commercial payer data. This is Blue Cross Blue Shield, who has had payment parity for since 2016. And you can see the same thing, that even with payment parity, you're not seeing care levels exceed what they were prior to the pandemic. In fact, it's actually being used as a substitute. So in no way does that necessarily say that that won't happen in the future, but at least for now, there's no evidence of this overuse occurring. This is a quick study that I want to present. We did this a few years prior to the pandemic. And what we did was we actually had a medical student that was watching video visits occur in in-person care, and they had a stopwatch, and they were actually timing how long each one of these visits were, how long it took to have for a patient to see the clerk, the checkout line, everything like that. And we calculated the We used a method called time-driven activity-based costing to figure out exactly how much these visits were costing, in-person care and which we call traditional care, and physician-led video visits. And what we saw was that they were essentially a wash. They were costing about the same for the clinic. And that's because the majority of that cost is how much time the clinician is spending with the patient. And at least for our sample of general surgery and urology clinics, we found that clinicians were actually spending more face time with the patient during the video visits, which made up for the small amount of time that they spend with the checkout clerk and other resources in clinics. So we essentially in this study, we found that the costs were about the same. And there's a million ways to look at this. And I still think that there's more research that needs to be done in this area. But at this point, there's no evidence that payment parity has led to overutilization of telehealth. And then the underlying costs could be actually no different than in-person care. And I'm happy to get into that discussion if anyone's interested. The policy relevance here is that there's really more need for research to align telehealth payment rates with delivering the cost of delivering these. And I don't think it's very straightforward, but at least it's important, and I'm optimistic that there are still bills out there that extend the public health emergency flexibility so that we can collect more data over time and really figure out what's the right price for these. And finally, I'm going to end with a policy issue number 6, which is avoiding overuse for healthcare services. And so I did show some slides earlier that talk about overuse that were mostly focused on payment parity and the individual visit. But I do think it's important to understand how individual visits may lead to downstream visits and lead to overall more care, more expensive care, total cost of care. Prior to March 2020, we have no insight on this. 99% of care was delivered in person, so we have no idea whether telehealth is going to lead to more healthcare service use. 15% to 20% of care is now being delivered via telehealth. And so when I see a patient, do I have all the information I need to make a decision on them? And am I able to end that visit there? Or do I need, if I see them through telehealth, am I still going to bring them in for the exact same visit in person? So this is an important question that needs to be answered. We're addressing this in multiple different ways, but how does the new mode of this new mode of delivery change clinical care delivery? Obviously, there's a lot of concerns about healthcare spending, and there are regulations that are being set up. For example, the Medicare program said that they're going to set up guardrails where you can do for mental health. This happened this year where you can do mental health visits through video, but at least once a year you need to see the person in person. Now, is there any evidence for that? No, we have no idea whether that improves care or does anything for care, but there are these guardrails that are being put in without evidence because they don't want overuse of healthcare services. So this is a study that Kathy Lee, who's a fellow that worked with us, emergency room physician, and she did this study where we looked at how telemedicine affects downstream care for symptoms of an upper respiratory infection. So you come in with cold and flu symptoms, you can either see your primary care doctor in person, or you can do a telemedicine visit. And these are going to cost about the same. That was the group of patients that we looked at. We had a matched control. And what we wanted to look at was what happened afterwards. Was the issue resolved or was it unresolved? And did that lead to a secondary visit either in person or through urgent care or through the emergency room? And so when we looked at the data, what we found is the majority of encounters, over 90% of the encounters for both types, did not require any follow-up care. So everything was handled in that first visit. But we did see that telemedicine actually led to a slightly higher rate of secondary visits. And those secondary visits occurred in the office and through telemedicine. So the blue bars represent the rate of secondary visits through when the initial visit was through telemedicine, and the yellow bar represents the rate of secondary visits when the visits were through in person. And you can see that for the office and for telemedicine, in terms of those secondary visits, there were higher percentages. Overall, the difference was about 4% for secondary visits. Main takeaway from that study is that telehealth is an effective modality. We still have a lot to learn about downstream care and how effective it is in handling clinical situations in the same number of settings as in-person care. Follow-up care after telehealth visits should be considered by policymakers when evaluating the impact of telehealth on healthcare spending. It's an important metric that never needed to be studied before. So that's it. I just went through kind of 6 of the questions, 6 policy issues and the data that we have. There's a lot more. We've been doing a number of studies. Mike Thompson has been very involved in this to understand access, costs of care, and quality of care related to telehealth. Our big aim is to not just produce the data, but disseminate it as much as possible. So we focus a lot on disseminating information. We've recently published a small book that was disseminated to over 100 different stakeholders about our research to help get the word out. And I'll end with this quote, because this kind of embodies the mentality that we have in the research lab, that technology is capable of doing great things, but it doesn't want to do great things. It doesn't want anything. That part takes all of us. So thank you again for the opportunity, Mike and Donnie and Holly in the department here.